Time now for this week's Health Matters. Paul Critz with you, and ordinarily I'm joined live in the Fug House with by PA Lynn Szabo, but you're calling over the phone today. Why is that, Lynn?
Oh, I had a pretty significant COVID exposure yesterday, and I woke up not feeling great.
Uh-oh.
So far, haven't tested myself because it hasn't even been 24 hours. But I just thought I would do the mature, responsible PA thing.
Okay, so let's just recap before we get into today's topic. If you are in fact positive for COVID, what do you do?
It depends who you're listening to.
Well, I'm listening to you. What do you do?
What I would do, which is different from recent changes in California, because my job has certain demands. I work with very vulnerable people.
Right.
Is I would isolate. I mean, stay at home for 5 days, and then only go back into clinic when I'm testing negative. But that is not the current recommendations. So.
Oh wow. Okay. But I mean,
yeah.
Is it not the current recommendations because just because they don't apply to you as a healthcare person?
No, it's because I work with vulnerable elders, pregnant women, and newborn infants, and I am not bringing this to them. So
yeah, that's exactly what I said.
My feeling is that I'm not going to go with what California is recommending, which
right.
is in contrast to the CDC.
Yeah, so. Gotcha. Okay.
Yeah.
All right. Well, then, I suppose. I mean, the next question is: are you sure you're not just all making this up in your head?
Totally.
You're not a hypochondria?
I suppose so, because I haven't actually tested yet, but it hasn't even been 24 hours. So,
when that brings us to today's topic.
Hypochondria, but we don't really use that word. We try not to use that word because what it sounds like to a patient is you're crazy, go away.
Right.
And that's not really what we mean by that. I like that. There's a lot of different ways to label it, but right now my favorite is illness anxiety disorder because that feels like it's like the most real.
Okay.
So, yeah. So this came from a recent article in JAMA on the 13th, published on the 13th of December last year, so in 2023. And it's titled All Cause and Cause-Specific Mortality Among Individuals with Hypochondriasis. And the names, we just talked about the names, but I'm going to say the first one is Maytai, Isomura, and Siderchuk et al. Oh,
I thought you were asking about possible pronunciations for these words. I thought they were names of medicines. These are people.
No, they're human beings.
Okay, so, all right.
We have to have respect for names. Names
right.
are important. Anyway,
right.
So in JAMA, so this study asked the questions: are individuals at increased risk of death due to natural and unnatural causes if they have the diagnosis hypochondria? Okay.
Wow. So first off, my question is, there's an actual diagnosis for hypochondria. Of course, now we're calling it illness anxiety disorder, but that's something that you can be diagnosed with.
Right.
Okay.
And there are I'll get into what other things it might be called besides hypochondria. Hypochondria, I don't think is a useful word. It's got too much stigma.
Yeah.
But so what this did was they got the electronic health records in Sweden because they have one nationally because they have universal medical care for people. And they looked retrospectively at about 41,000 Swedish citizens. And they matched those 41,000 with a specific 4,100 people with a diagnosis of hypochondria to specifically look at causes of mortality.
Okay, so I want to stop right there because there is some confusion in what I'm reading and what I heard just now. So they looked at 41,000 Swedish citizens from their wonderfully progressive.
More like 45. It's more like 45,000.
Okay, whatever. Don't mix it up with that. Let's just stick with the numbers that are on here. And then you say matched with about 4,100 people with diagnosis of hypochondria. What's that mean? Matched with?
So they got people with similar demographics, similar educations, similar lifestyles, similar economic, locations in society.
Gotcha.
So they tried to match them up.
Okay.
And what they found was that people had been diagnosed with hypochondria were at increased risk of all-cause mortality.
Ooh.
So we talked about all-cause mortality last week. So that's dying from like every possible thing you could die of.
Right.
Okay. So they didn't limit it in any way. So people who have what's known as hypochondria or illness-related anxiety have a higher death rate from like everything. And when they looked at I know. And so everybody out there is going, yeah, see, I told you I was sick.
So, but but there's so many ways that could, I have so many questions now. Let's just go ahead. I'll let them bubble up.
And so many of the causes of death they found were preventable. Okay. And then they also had an extremely low risk of dying of the health concern that the patient was focused on.
Oh, that's horrible. So
what it seems like to me is that somebody gets worried about a particular thing, they either don't seek care because they're afraid to know what it is.
Right.
And so a certain amount of people with hypochondriac don't even seek care because it's just too anxiety provoking for them.
Uh-huh.
A certain amount do seek care, and maybe they get a bunch of tests and everything pans out and their doctor says, look, this really isn't something that's going to be significant to you and a health thing, so you can let go of your worry about it. They get mad and they continue to focus on it. So they go from primary care to secondary care because they want to talk to a specialist at this point.
And so
that's actually where
it follows along then that they end up dealing with whatever the issue was because they kind of the hound they go down that path as far as they possibly can.
Right.
Okay.
And what's kind of interesting, we talk about it a little bit later, but they don't really get diagnosed with hypochondriac at the primary care level.
Mm-hmm.
They get diagnosed with hypochondriac at the specialty level, which is the secondary.
Why is that? Is
secondary
it what makes it more visible to the healthcare specialist at that point?
Well, I think the healthcare specialist is more honest in what they're saying, and the primary care person is more trying to maintain the relationship with the patient to have a beneficial therapeutic relationship.
Like the specialist. The specialist, to a certain degree, doesn't have time for your for your hypochondria.
It's not really. No, the specialist doesn't have an ongoing relationship, so there's no therapeutic relationship with this patient beyond a couple of times that they see him, and they feel like they can be more forthcoming and direct.
Yeah, again, kind of feel like I said the same thing, but sure.
Right, okay. Sure, whatever.
So I don't mean to cut to the chase here, but is it the anxiety that's killing these people then?
Yes, actually.
Wow.
And here's where it gets so. Overall, they have the following: people who died of increased all-cause mortality with a diagnosis of hypochondriac had 4 times the risk of suicide.
Well, okay, sure.
Which is super sad.
That is.
And then sometimes they were avoiding healthcare.
Uh-huh.
So they would die of whatever else killed them.
Right, head in the sand.
Healthcare.
Yeah.
Because they were too anxious about what the possible outcome could be.
Mm-hmm.
And then also the authors thought that chronic stress played a part in the deaths.
Right.
So, it's the underlying anxiety disorder. So what that means to me is that this is an expression of an anxiety disorder, not an undiagnosed, disaster.
So they had the following. You've said down here too. There was one that you didn't read, as well as lifestyle factors such as alcohol and substance abuse, which I guess would follow along somebody who's suffering from heightened levels of anxiety.
Yeah, I'm trying to self-treat.
Right. So, and you said you've seen this sort of thing.
I see it in a lot actually, and it's really sad to me. And so I say from my experience, sometimes patients focus on a perceived illness and they overlook everything else.
Is that...
And so they ignore things and they are unmovable from their focus. looking at other things that are actually more dangerous for them.
So is that the line, that sort of that hyper, almost unreasonable focus? Is that when, like, I mean, everybody's going to have anxiety over health if you're going to the doctor about something, but
you can calm. Yeah, go ahead.
No. I'm just asking for your experience of that line. At what point does that kind of run of the mill anxiety walking into an exam room? When does that become hypochondria?
I think if I have definitively proven 3 times that they don't have what they're worried about, then at that point I say, look, obviously you're not comfortable with this, with my evaluation here. Let's send you on to secondary care. So kick the can down the road, right?
Okay.
And there's buy-in to that because, there's the thought, well, maybe she's good for routine healthcare stuff, but this is beyond her scope of practice.
It seems like
which isn't really true.
If I were okay, hold on. I want to come back to that because I understand. If I were suffering from illness-related anxiety and got referred to a specialist, yeah, that'd make my day, right? I mean, yes, that feels like validation, but it isn't.
Right. Not necessarily. So the first thing that happens up here, because it's still Nord, is there's no specialist.
Yeah.
So people demand referrals to specialists all the time that don't exist here.
Oh my gosh.
Especially if they're new to the area. So, and they don't understand what rural medicine is. So the next thing is the specialist has a screening process because they want to take care of people that have interesting pathology and they don't want to have to, they want the primary care person to endorse hypochondria as the diagnosis and deal with the personality and kind of maybe the angry response to that. Mm-hmm. So,
and it's also, I mean,
so then you got this barrier, and then if you can get past the barrier, and the insurance will pay for it, but the insurance will say, "Hey, but this looks like this is, wild goose chase. We don't want to pay for it." I mean, you have all these barriers, so you finally get past all those barriers, and then the secondary specialist will just say, "Well, you're okay. I don't know what to tell you. Go back to your primary." And we'll do watchful waiting,
right?
Which all that does is for an anxious person is make them more anxious. So,
does a diagnosis of this sort of anxiety, illness-related anxiety, does that help? Does that help a person? Have you found that? Is that something that they can kind of hang their hat on, or is that a hindrance?
Almost 100% of people will take offense, and then they'll say something. They almost universally say, "So you think this is all in my head, or you think I'm crazy?" And that is not at all what we think. Mm-hmm. We've looked into the matter to the extent we can look into it, even to the specialty or subspecialty level, and there's nothing there. And what's happening is that the perceived problem, the anxiety, sucks all the air out of the room, and you really can't move on in a more constructive way to make more meaningful changes in their health.
Right.
And then it becomes, they just think you're not the provider for them. It really damages the therapeutic relationship.
Wow.
Which is, I think, super sad.
Mm-hmm. Mm-hmm.
Especially when things get overlooked, like routine healthcare things, like, high blood pressure or high cholesterol, or update cancer screening diagnoses or cancer screening recommendations, things like that. And then what this study is saying is that hurts the patient, that missing that preventative health care in the long run is not good for them.
Right.
The other thing this study is saying is missing depression and anxiety and maybe substance abuse is also not good. If you have a 4-time increased risk of suicide.
Yeah.
So you're missing the real issues, and you're focused on something that is already not a problem. by definition.
Is there any magic bullet, anything that you can do? I guess maybe it varies person to person, patient to patient, but how you can address that, broach the subject of perhaps there being anxiety-related illness?
Yeah, I do it kind of indirectly. I'll say, you're worried about this thing that you perceive in your body, and so far we haven't been able to find anything that might explain it. It certainly is kind of weird. I'm wondering about your anxiety about it, though. Can we focus on that for a little bit, and then I'll try and treat their anxiety. Anxiety drives a lot in medicine. I think it's the most common thing.
Wow.
I mean, think about it. You get sick, you have a little anxiety about your symptoms. What do? You go to seek care.
Right.
So I try and flip it around and not call it hypochondria, or I just say, look, this anxiety is such a burden to you. How can I help you with that? And then that sometimes you can make meaningful changes there. And then the person kind of releases their obsession a little bit.
Is there any way to treat this sort of anxiety?
Yeah. Yeah, selective serotonin reuptake inhibitors. Lexapro is the most common one, which is an antidepressant, but it's largely used. Anxiety is a presenting symptom of depression in most people, and so this particular medicine is helpful. And there are a lot of people in the county on it. If we had a well-resourced county, we could also send people to counseling.
Right.
That's actually the most effective thing. And, they can investigate what might be the source of it. Maybe there's some post-traumatic stress disorder stuff going on, and that can be directly treated. Or it's like somehow they can get people to look at it in a more constructive way instead of focusing in a destructive way.
And you said, you mentioned, if we were in a well-resourced community,
Right.
and then you'd also, at that point, once you reach the counseling sort of stage, you've already, I would assume it would be standard to already have exhausted all the secondary healthcare options that would be available to somebody in a more connected community.
Yeah, that could exist. Yeah.
Like you wouldn't go to counseling until, at least if I were a hypochondriac and didn't know it, I wouldn't even listen to you talk to me about counseling until I'd exhausted
Right.
going to the specialist who would tell me, hey.
Yeah, and then the specialist writes a really kind of condescending note and says, "Why isn't this person in counseling?"
Yeah, there you
So poor primary care people, they can't remember.
That's what in the trenches, man, in the trenches, front line. That's why they call you guys frontline healthcare people, right? I mean, oh man.
Yeah, that's right. It's right. We have to be all things to all people at all times, especially Delmar. But I do want to add something that I think is super important. I do think people manifest stuff in their lives with anxiety. So if you think about it, worrying or being anxious about something is like meditation for the worst case scenario.
Exactly. That's your
Exactly.
negative visualization. Yeah.
Right. And I have seen in my life people manifest things that, how to explain it, manifest things that actually killed them over time.
Oh, wow.
And it wasn't the complaint that they originally were focused on. Like, I remember one person, she's passed a long time, lived in Humboldt, and I wasn't her provider. I was kind of in her friend group. And she wanted to be put on disability. And for whatever reason that she thought that was the way to live her life, she focused on creating a lot of medical attention toward various complaints in her life, kind of ignored all the advice about healthy living that she was getting. And she eventually manifested MS. And I don't think she was targeting a way to die, but it just seems to me that from my kind of distant acquaintance kind of relationship with her, that she asked the universe for a way to be on disability, and it answered with MS, which ultimately killed her. It was a very aggressive form of it and ultimately killed her.
That's such
and I didn't say that to her. I didn't say that to any of her friends or anything, but it alarmed me because I think it's a good example of you have to be very, very careful what you obsess about sometimes,
Yeah.
especially in medicine. And I have told people that. I have said, you have to be careful how you approach this because I'm afraid you might be setting yourself up for something worse in the long run.
Mm-hmm. Mm-hmm. That's interesting.
And it's almost never heard really because it sounds too much like blaming the victim, which is not at all what I'm doing. I just kind of watched it happen over the course of about 7 years.
Wow.
So, yeah.
See,
really
what
weird.
gets me about all of that, though, and it's kind of like, a chicken and egg sort of thing, or looking into somebody's eyes and trying to read their mind, right? Because there's one way from what you've told me, and I might not have them, certainly don't have any of the facts, but couldn't you also say that this person, could at the end of her life turn around and kind of look at all of us and go, "I told you so"?
Yeah, but what was wrong with her wasn't the complaints she had, and the complaints she had were varied and they were minor and they were always presented as the reason she needed a work note.
Mm-hmm, mm-hmm.
But I wasn't involved in her medical care, so I can't really speak to it beyond that.
Yeah, yeah.
And it's possible I'm grossly misinterpreting everything, but I was just astounded nobody else saw what I perceived was happening in her life.
Mm-hmm. Mm-hmm.
I don't think she was asking to die. I think she was asking just not to have to work anymore. For some reason, that was not the way she wanted to live her life, and she needed the financial support of disability. So she presented as needing that, and finally the universe, I think, in my opinion, gave her a reason to be disabled. Yeah.
I gotta say that's surprising to hear. That's surprising to hear from a healthcare provider, from a person in so embedded in science. I mean, because basically, you're describing magical thinking.
I know, but I wasn't her healthcare provider, so I didn't have to be in science land with her. But and I know very little actually about. I only know what her version was and what she was saying as a. Just kind of casual conversation.
Now, you were saying that this Swedish study also had some limitations?
Yeah, it did. So we should always make note of limitations in science. So it includes the fact that computers, oftentimes the diagnosis is in the computer is kind of hedged a little bit. And so we have different diagnosis codes for things that kind of mean the same thing, but are not as offensive if a patient ever gets a hold of the records. So people who have hypochondriasis may actually have the diagnosis of worried well or somatically focused or just covered by anxiety. And since they were pulling charts from the Swedish electronic health record, they could have easily missed another more accurate diagnosis. And, they talked about that in the course of their paper.
Okay.
So they're not really certain. Some of the matched, quote unquote, normal controls could actually have had hypochondria.
Right.
And that nobody ever used that word or, illness focused anxiety.
Exactly. So, they're having to infer from what they're pulling on these charts and kind of translate all of that to them. And it's always good to address methodology because that's where the devil is. Yeah,
totally. But I thought it was a good study. I thought it was a surprising study. I thought as a primary care provider, if I see somebody that I in my mind, I go, oh, well, they're just a hypochondriac. First of all, that hardly ever comes up. Secondly, I should strive to look deeper into that person's presentation and health history and motivation maybe, and how I can best reach them in a place where they can hear what my concerns are.
Right. Right.
So, and then you and do it all in 7.5 minutes.
Yeah. Yeah.
So,
Oh, God.
yeah, sure. No problemo. So,
Oh my gosh. All right. Well, Lynn, thank you very much. That's really interesting. And
it is.
I don't know. Does it seem like to you that just are we already learning? Have we already learned a bunch, or is this going to be like a kind of an open sort of a horizon for medicine in the next century? But anxiety and just the kind of the mental states that affect us, very real. It seems like the very real affecting of
Right.
our physical states.
Oh yeah, the ties between the brain and the body are, we still don't understand even a little bit of it. So
Really?
as we
Really?
understand it more,
Yeah.
then I think we can present our concerns in a way that doesn't sound offensive to the patient, and maybe we can get the patient on a better, healthier track.
Mm-hmm.
That's my hope.
Yeah.
Yeah.
And one level, it's like, sure, it's all in your head. Everything is all in your head. So of course it's
and
all.
it's too bad that's such an offensive phrase,
Yeah.
in this situation in the exam room, because that's not all what I'm saying, and I have to explain that a lot. Where I say, look, I don't think it's all in your head. I totally believe that you're having, this fill in the blank. Usually it's pain, or feeling like an asymmetry in your body, or feeling something that worries you. But I have to address that with more than just an X-ray or CT scan or a referral to a specialist.
Right.
I have to address the feeling that you're having about it, and how we can best manage that, and whether it's detrimental or whether we can give you something that'll help make it more positive. I think.
Wow.
Yeah.
Well, thank you, Lynn. That was that's really thought provoking. That's
I think so too.
I am
It was an interesting paper.
I am a self-diagnosed hypochondriac. I know this about myself. I have known it about myself since I was a kid. I could, and I'm just the times I'm going, oh, that's it. I'm getting sick. It's the end. And then a half hour later, I'm fine. And I'm like, okay, all right. That's
Right.
just, I'm very suggestible in that regard, at least. But, but yeah, I don't know. I've had things that were anxiety related that totally felt like a heart attack and a trip to the ER, right? And then after a couple of those, you're like, okay, I see how this might work, and at least that helps mitigate some of that panic.
See, you have the ability to trust to get the information from the ER that you found useful, that you incorporated it in a healthier way, instead of just insisting they missed your heart attack.
Yeah. No, that's true. Because
that's good.
I didn't want to have I was kind of listening for that that validation that isn't the heart attack. I was hoping for and I kind of clung to that. Right. Okay, it's not my heart. Great, right. I can go worry about something else.
Right. And then the opposite thing that my kids, if they were on this show, would say, don't have a PA for a mom, because there's never anything wrong with you, right? Every time they come in and they're certain they're dying, and they call me up, and I'm like, no,
suck it up. Come on.
Yeah, you still have to go to school. You still have to go to work. Yeah.
Oh, man. No flies on you, Lynn. Well, Lynn Szabo, PA, thank you so very much for this week's Health Matters. Any thoughts about next week?
No, I'll see what the week brings me, actually.
Yeah, you might... Are you going to be able to just to be at home and just be at home, or kind of wait and see if you get sick?
I'm going to see if I actually get sick. I feel fine, but I didn't want to come in because, I'm not sharing the wealth with anybody.
Yeah, thank you.
I don't have to.
Let's keep that. Yeah. Let's keep that R naught number down, right?
Yeah. Even though California seems to be like moving in the wrong direction for that, but okay, whatever.
Yeah. Well, thank you very much, Lynn, and hopefully we'll be able to see each other in person this next week. And don't get sick. Have a good week.
Okay, thanks. You too.
Okay, bye-bye.
Bye.